So now we're going to talk about facilitating hygiene or bathing our patients, taking care of our patients in that manner. And it's a very important thing to do. And I've heard nurses say, well, bathing, that's for the nurse aide. Well, actually, it's a really, really good time to take a good look at your patient and assess them. You get a chance to look at their skin really well. If they're able to get up and move around in the room, you can look at their mobility, look at their range of motion, just look at themselves in a whole. You can listen to their lungs before they get up, and as they move around and start coughing, listen to their lungs after to see if there's a difference. So while your patient's being bathed, it's a really good time to step in and just take a quick look. So hygiene, when we do it, it's involved in maintaining the personal cleanliness and grooming of somebody. It works with their activities of daily living or the things that we do every day to take care of ourselves. So multiple factors influence our hygiene. Personal preference, do we bathe every day or not? Do we shower? Do we bath? Do we do a little of both? What does our culture and our religion or our spirituality bring into this? Do we receive a bath from a male or a female? Do we have to do it ourselves? Do we only bathe on certain days? Are there certain holidays that we don't? What happens? The economic level. Are homeless or our lower socioeconomic people? Do they bathe every day? And if they don't, why? What's happening? Developmental levels. Babies don't need a bath every day. Little older people don't need a bath every day. A lot for the same reasons. Older people, their collagen is depleted. They've lost their elasticity, and if we bathe them too much, we dry their skin out. Preteens, teens, we've got acne, we've got oily hair, we've got this, we've got that. They've discovered their bodies, their hormones are flying, and little boys especially smell. They could bathe 4 or 5 times a day, and they still smell. Just one of those things. Cognitive and knowledge. As we lose our cognitive ability with dementia, Alzheimer's, and so forth, we not recognize that we need to bathe. And our health status impacts it too. Depression, I don't want to bathe, I don't need to bathe. Physiological things, I'm in a lot of pain, I don't have the range of motion I used to. I'm obese, I can't reach my feet. I have hip problems, I can't bend to reach my feet. My muscles hurt, I'm just weak, I'm tired, so forth and so on. Sensory issues, visual, I'm blind, now how do I bathe? Um, Dementia, Alzheimer's, they may forget the steps, they may forget to bathe in general. Also, with the loss of smell, your older people may not realize that they have a little body odor going on, and they cover it up with whatever perfume or cologne that's popular for them these days. So, lots of reasons that we are around bathing and not bathing. So the overall goal of hygiene is to promote self-care. We want our patient to deliver as much of their own hygiene as possible. And we base that on functional level. Can they do it alone? Do they need equipment or device or someone to supervise? Hey, don't forget to get under your arms. Don't forget your private parts or whatever. Do they need a hand? I see that you can't get your feet. Let me get your feet for you. Or totally dependent. Do I have to do it all for them? So in order to determine the level, we need to look at their cognitive ability and their physical function, their sensory, their mobility, are they in pain, their culture, religion, and what they prefer. Okay? We have different types of scheduled hygiene, hourly rounding. When you end up working in the intensive care unit, a lot of oral care on those patients with ventilators every hour, so we don't get ventilator-associated pneumonia. Early morning before breakfast, we come around, we get them to wash their face and hands, maybe brush their teeth or wash their dentures or whatever. Same thing maybe in the afternoon, or then get them ready for sleep. Some units have routines when they do baths. A lot of units, if you have someone who is complete total care, out of 30 patients, you've got 6 of those 6 patients might be done at night by your nurse aides at night, and the others are done during the day. And it just really depends on the routine of the unit. We can delegate hygiene care, okay? In most hospitals, the nurse aide or the unlicensed professional will do it. But consider if it's appropriate. Sometimes it's not. Sometimes the nurse needs to do it or at least be a part of the process. Um, But as I said earlier, it's a great opportunity for you to assess your client's level of consciousness, their short and long-term ability, their ability to follow instructions, their range of motion, their skin integrity, their activity intolerance, and just their overall ability to take care of themselves. This might mean when you realize, oh wow, Mrs. Smith can't go home because she knows she's got 4 flights of stairs to get up, and she can't even take 4 steps to get to the bedside commode. So, choosing a bath type. A lot of it is your nursing judgment. Some of it is client preference or their ability to do it. And sometimes it's the medical plan of care. I've seen patients that are really too sick for a bath, and you just have to work around that. So, an assist bath, that's where we help with the areas that the person can't reach. Like I just said, oh, Miss Smith, I see you can't reach your feet. Let me get those for you. Partial bath. Some people, you'll say this is what we call a bird bath. We hit the high spots, the axilla, the perineum, the parts that might tend to have a little odor or discomfort or whatnot that we just need to get for today. And then a complete bath when they're able to wash their entire body without assistance from the client. So that's your nurse aid. This is also kind of a older nurse like myself will call that a bed bath. We do it in the bed. Towel baths, you can read about those. We don't do those a lot. They take a lot of time to do, and actually we do. It's like the prepackaged Clorox wipes. They're really good for patients with dementia and Alzheimer's. You can hit the high spots without agitating them, so forth and so on. But nothing beats a real good bath. Okay, we don't use a whole lot of basins in warm water anymore because of the recontamination of the basin. And we need to avoid showering for those people who are immunocompromised or at risk for infection. Warm water in the shower opens the pores, and which is then a direct link to infection. Talked about bathing clients with dementia. They often get agitated when it's time to bathe. They're scared. They don't realize what's happening. They may be in pain. They've lost control. So this is when your wipes are good. Doesn't need to be at the same time every day. And it might be that you get their axilla this time when you give meds, and when you come back in a little while and you've got them up going to the bathroom, that's when you hit the other spots. But you know what? If it's that big of a stress to them today, let it pass till tomorrow. But don't let it pass to the point where it gets out of hand. Bathing the morbidly obese client is another issue. We need to make sure we're doing a thorough skin assessment in these people, getting in, looking at those skin folds. Controlling moisture is a big issue. Just because you get it wet does mean you need to dry it. So if you get up underneath those folds with some good soap and water, make sure you also get up underneath those folds with a good dry towel, because if you don't, that traps moisture, which then breaks down skin. It can cause pressure areas in the folds, so forth and so on. Their skin becomes a shearing force. We may need to look at their nutrition so that we can get some protein in them and whatnot. So our older person here, our goal is to prevent the drying and the injury of the skin. So we want a no rinse pH balance cleanser and some moisturizer. We don't want to use a lot of perfumed soaps or soaps with a lot of microbacterial in them, those kinds of things. Just something very, very pH balanced. Tepid warm water. We don't need really hot water because it does tend to dry their skin out. Okay, diabetic foot care. This is extremely important. What happens with diabetes is over time they develop neuropathies. They have tingling and numbness in their feet, and therefore they don't feel and weakness. They don't feel any kinds of nicks or cuts, and therefore they don't pay it any attention. The next thing you know, they've got an ingrown nail or a cut on the bottom of their foot that becomes infected, and infections in diabetes are not good. So the next thing you know, this cut on a toe is now leading to an amputation. So it's really, really important that we look at our diabetics' feet, we keep them nice and clean and dry, and that they have the right shoes and socks and so forth. Oral care, I talked about that earlier. It's really important that we provide really good oral care, especially to our older people and especially to people on ventilators, so that we prevent ventilator-associated pneumonia. So we prefer most places use something called chlorhexidine. It's really good to clear the bacteria out of the mouth. We also started bathing people in this on a regular basis. We want to use a soft toothbrush or toothette like you see in the picture of foam rather than a hard one. People who are unconscious or unresponsive, we tend to breathe through our mouths when this happens. Our mouth dries out. So we may want to keep the mouth moist every hour, running by, cleaning their mouth out, so forth and so on. Foam swabs can be used. It can just be water. Too much of this chlorhexidate will be bad, but some water. But a couple times a day, clean it out just like you're brushing their teeth. They need some good oral care as well. What you need to stay away from are like the lemon glycerin swabs that taste like lemon. Any of that citrusy stuff dries it out, changes the tooth enamel if they have any tooth. Hydrogen peroxide is the same way. We want to keep a nice pH balance. Dandruff can be caused by fungal infection. So if you see a little person who's got a lot of dandruff, start looking at their scalp to look for a fungal infection. You might have somebody who has alopecia, very thinning hair from various reasons. We use dry shampoos usually in the hospitals. The shampoo cap, which you see in the photo, it's a no rinse product. It's going to clean their head, clean their scalp, but their hair's not going to be, GQ ready. It doesn't look as nice and full as you would if you had it done in a salon or even your own personal products at home. We will shampoo somebody's hair in the bed. Usually a family member will want to do that. It makes a mess. It's cumbersome to do, but they usually feel better when we do it. But like I say, that has to be coordinated and done the right way. Eye care is very important, especially your patients who are comatose or may have a stroke. They lose their ability to blink and their corneas dry out. So we need to make sure that we lubricate their eyes with either saline or artificial tears every couple of hours. If this is a prolonged problem, we will close the eye and use a patch to keep the eye closed. We still need to make sure that the eye is cleaned and lubricated, but not maybe quite as frequently if we keep it closed. You will come across a patient who might have an artificial eye. If so, it's just like dentures. It will, from time to time, will need to be removed and cleaned using sterile or aseptic technique. You need to wear sterile clothes, so forth and so on, and follow your procedures on how to do that. I've had to do this a couple of times. It's not the most pleasant thing to do, but it needs to be done. So room temperatures, we need to keep room temperatures sort of normal, but remember your person it's their room, it's their home. So keep that in mind. Also keep in mind their pathophysiology. For example, renal patients are often very cold. They have no hemoglobin, so therefore they don't carry oxygen to perfuse. So it'll be 105 degrees outside and you go into room 12 where your renal patient is, and they've got the thermostat set on 95 and they're sitting there covered up in 2 blankets and all you see is their face and you're sweating like a pig. It's their room. It's their choice. But too extreme cold, too extreme heat is not good either. So here is a picture of some bed positions for you to use. Not really anything testable, but just know that we can move our beds around to help us position our patient, move our patient around to help us so that we don't hurt our backs. So that is the end of your hygiene, restraint, and safety lecture. If you have any questions, please feel free to email me, hudsond@queens.edu.